everyone. Let me introduce you with today's guest speaker, Dr. Urvi Shukla. She is MD, DND, MRCA, EDIC, and FICCM, postgraduate in anesthesia and critical care in 1998. Went to UK for further training in critical care, cardiac anesthesia, and has been a senior consultant in critical care at Aditya Birla for 9 years before joining SUHRC. In her stint at Aditya Birla, she set up the deceased organ donation program, liver transplant unit, and also she is a teacher for DNB Critical Care and IDCCM Critical Care program for last 5 years. We can start with the lecture.
Thank you, Preeti, and thank you at the outset. Let me thank SSODL for inviting me for this topic. The topic today I have is roles and responsibilities of Hospital Infection Control Committee. I hope my slides are visible and I am audible. Yes?
Yes, ma'am, yes.
Okay. So starting with my presentation, what is Hospital Infection Control Committee and what is Hospital Infection Control Team? So the committee is made up of people who process the policies, who frame the policies, and the Hospital Infection Control Team are the individuals who actually bring or implement those policies across the hospital departments. Now, why do we need a hospital infection control committee and an infection control team? So there are multiple reasons why this team is absolutely mandatory in any hospital setup. The most important reason being that healthcare associated infections are the most common complications of any patient who is hospitalized for any reason. It increases patient morbidity, mortality. It also can increase the length of hospital stay and can lead to increased costs. It also leads to increased litigations against doctors, against hospitals. The HIC becomes the backbone of safety for the patients and for healthcare staff. It strives to ensure safe delivery of healthcare services to the patients. It ensures safe working environment to the staff as well, and prevention of hospital-acquired infection is a major component of international patient safety goal. So these are the reasons why Hospital Infection Control Committee and team are absolutely mandatory for any modern working hospital. So what are the policies that the HIC is involved in? So these are the basic. HIC is basically a multi-pronged surveillance, implementation and prevention unit. It deals with prevention and control of infection. It forms the antimicrobial policy, the surveillance policy, the disinfection isolation policy, and if there are, in spite of all of the precautions in place, if there is an outbreak of an infection within the hospital, that this is the team that is responsible for its investigations and for its mitigation. So basically the aim of Hospital Infection Control Committee is to produce evidence-based information for prevention and control of infection. And we are not only talking about healthcare infection for the patients, we are also talking about healthcare associated infection that the healthcare staff may contract while performing duties as in taking care of the patients. So it is relevant to all staff. So the doctors, nurses, housekeeping, cleaners, porters and administrative. And the final aim of this committee is to update as and when necessary. Remember, the kind of microorganisms that we grow within the hospital environment are not static. What we grew 10 years ago is not what we grow right now. And I'm sure 10 years down the line, we will have extremely different kind of microorganisms which we will be growing in the hospital environment, and we will have probably very different techniques and tactics to deal with those kind of organisms. So updating and keeping abreast of the situation is absolutely mandatory so that the surveillance can be done in a timely fashion and an outbreak can be prevented. So now coming to the hospital responsibilities of the infection control team. So these are the team that actually implement. So they are the ones who are doing the field work basically. The hospital infection control committee may have multiple members, but the infection control team are the ones who are the eyes, the nose and the ears of the HIC committee. And without the infection control team, it is absolutely impossible to find out what is happening in the kitchen or maybe in the OT or maybe in the intensive care unit. So they are the ones who are the eyes, nose and ears for the HIC. They have to be empowered. You cannot have an infection control nurse who doesn't have the authority to even tell the doctors that they need to perform hand hygiene before they touch a patient. So if the nurse is so suppressed and is unable to even open her mouth, then your infection control team is no good. They are not going to be able to do their work, in the sense they are not going to be able to protect the staff and the patients from acquiring hospital acquired infections. So you need to give them teeth, you need to support them, and you need to make sure that see what happens is medicine is a very hierarchical field, and very senior doctors, they claim a lot of authority. And when you have a new infection control nurse who is patrolling, being your inspector, being your eye, and trying to see what all is going wrong and why patients and the staff are getting infected, she needs a lot of support to try and face that very senior doctor who's going to be there and not following hand hygiene rules, or not following or not complying with hospital infection control policies. So if you don't support the field workers in the hospital, you are not going to achieve the designated or the designed results or the outcomes of hospital infection control. So they are the ones who will keep a watch on hospital acquired infections. They will develop a system to identify. So identify where a problem is occurring. After they identify, they are going to report to the hospital infection control committee. They all will sit down to analyze why a certain thing or why a compliance is not followed. They are going to sit and investigate that who all are going to be responsible, what kind of training these patients or these healthcare staff will require, and eventually that is how they are going to be able to control. So your HICT is your backbone. They are actually the eyes, ears and noses of the hospital infection control committee. So they are going to be the ones who will implement the preventive and corrective program. They are going to assist with antimicrobial policy compliance, because doctors are not going to otherwise listen when you tell them, please do not give meropenem for community acquired urinary tract infection. They can be treated with simple nitrofurantoin. But they are the ones, your hospital infection control team are the ones who are going to assist. They are going to be the ones who will actually talk to the colleagues or talk to senior doctors in a manner that those doctors understand, and make sure that the compliance is ensured. And they are the ones who will make changes as per the changing evidence. So this is, so I hope I've differentiated the hospital infection control committee and the hospital infection control team. So they are basically under the gambit of hospital infection control, but they will have different roles to play. So finally, what is the structure of the HIC committee? So you basically have the head of the institute. Preferably you will have your CEO or director operations or COO, whatever designation they may have in that hospital. You need a senior microbiologist, because a lot of microbiological samples need to be assessed. They will have to have data for years together about how the organisms that cause urinary tract infection are changing. They will be the ones who will give you the sensitivity reports and will also identify how sensitivity patterns are changing. You will need representation from management, administration, the dean or director of the hospital, nursing services, medical services, and operations. Remember, like I said, your infection control nurse is going to need a lot of support from all these authorities. Otherwise, she or he, they won't be able to fulfill their duties. You will need medical faculties. You will have to involve all faculties, all specialties, and senior doctors in all specialties to make your program successful. You will not be able to work in silos. Because this will have to be a continuous interaction between the clinical staff and the HIC committee. It will have to be working in great interaction with each other. You will need support services from the OT, housekeeping, sanitation, engineering, pharmacologist, store officer, and material department, because these are all going to be useful while you implement your services. You're going to need an infection control nurse and an infection control officer. So the nurses, officer, irrespective of their gender, they are the ones who will be actually doing the field work for you starting every morning. So this is how the structure of an infection control committee is formed. And what do? They do the surveillance. They get up in the morning, they punch into the hospital, and the first thing they do is they collect their own their registers, and they start moving around the hospital. They do systematic collection, analysis, interpretation, and dissemination of data about what kind of healthcare associated infections, HCAI, are healthcare associated infections, are occurring in the population, in patient population. So you may have different kind of infections occurring in a surgical patient population, a different kind of hospital acquired infections occurring in medical patient population. So you will have to have somebody who will keep a note of what is happening to each and every patient while they are in the hospital. So your hospital infection control nurse and the infection control officer, that is how they are going to get this data. They are going to then find out what are the endemic rates. So you cannot have a situation where nobody ever gets a healthcare associated infection. So there will be kind of a small low level background that n number of infections, whatever you do, you achieve, you still get in the patients. So those are the endemic rates. And over and above, there will be situations like, now if we talk about the recent real life situation, it is what happened in April, May and June when we had the second wave of COVID. All the ICUs across the town, cities and in Maharashtra were full, and everybody was stretched. So otherwise ICU nurse would be handling one ventilated patients. In the COVID surge times, they were handling 3, in some places they were even handling 4 patients. So it was physically and practically impossible to have the amount of hand hygiene or infection precautions as would happen when right now. So right now we have like 2 or 3 COVID patients in the ICU and 5 staff. Okay, so the kind of healthcare, kind of infection control or infection prevention precautions that we can do right now, we were not able to do in April, May and June. Okay, so at that time we had a big surge even in secondary bacterial infections in COVID patients in the hospitals. Okay, so this was over and above the low grade infections that we were seeing at other times. Okay, so this is what I mean. So there will be some baseline endemic rates of HCAIs where you will have to, in order to keep that baseline really low, you will have to work extra hard. You will have to put in extra effort to keep on training and retraining all your hospital staff in infection prevention protocols. But when you have a surge like we did in COVID, your endemic rates are going to go out of the window. Whatever control you had achieved before the surge started is going to go haywire. You are going to have infections which will absolutely dominate your sense of discipline. And this is the time where you need your infection control team to come together and to work at speeds that are unheard of. Okay, so they do that. They also identify an occurrence of an epidemic. So anything that rises beyond your endemicity becomes an epidemic. So there are ways and means to treat, to identify, to isolate, to find out the source from where that epidemic may have occurred within the hospital itself. We are not talking about COVID epidemic. We are talking about the epidemic of secondary bacterial infections that were occurring in severely ill COVID patients. So that was another epidemic over and above the COVID epidemic that we were handling. Then they will be the ones who will monitor trends over finite period of time. So last 6 months, what are the trends? Over last 5 years, what are the trends? So very good HIC officers, they may have data for even 20 to 25 years of the hospital functioning. So this is how important that data becomes. It is like a gold dust. You cannot lose that data. And they will be the ones who will do continuous observation of healthcare associated infections for prevention and for purpose of prevention and control. So when we talk about surveillance, so what are the areas that you want them to survey? So you can't ask them to walk across the hospital all day long. But we know from experience that there are certain areas in the hospital which are prone to more infections, where if the patient in that area gets an infection, have higher chances of complications, and those complications may turn out to be life-threatening for the patient and litigious for the hospital. So these areas are, as I have labeled them here, so you have the intensive care units, which includes everything. So your neonatal, pediatric, if you have different specialty intensive care units like respiratory ICUs or neuro ICUs or cardiac ICUs, then all of that put together comes under the gambit of intensive care units. The other areas where you want active surveillance, where in the sense you want your ICN to put a focus, to keep her eyes open when she enters that area, are the operation theatre, the dialysis burns unit, transfusion services, your food handlers. Remember the ones who serve food to the patients. If they have long nails, if they are carriers of salmonella, it is only a matter of time that the hospital patients will get typhoid while they are in the hospital. So you will have to be extremely careful about the food handlers. So the lesser, educated the workforce you have, the more the chances of complication. So if you have food handlers who come from extremely rural areas without basic education, it is going to become very difficult to teach them about hand hygiene, about washing their own hands after going to the bathroom or washing their own hands before they touch food for any patient. Drinking water is another big issue. All hospitals have big water tanks, dispensers that are installed at different places. And these the tanks or the water dispensers that are installed, they have lids that can open, and you sometimes can have no control about who's opening those lids. So you have people and visitors who may be opening the lids and putting their hands in that water and getting some water out in a jug or whatever. And these things become absolutely uncontrollable. So it is not just the clinical areas, but it is also the non-clinical areas where your infection control team is going to keep an avid watch. So that is the food handlers and drinking water. So coming to what is the definition of HCAI, it is infections that occur more than 48 hours after admission. And you need to understand that not all infections will have an incubation period of 48 hours. So depending on what kind of infection or what kind of microorganism is floating around, your incubation times may change. So every patient you will have to assess separately. But the commonest HCAIs that we see in hospital are ICU related infections. ICU infections are because ICU is a very high intervention area. So we tend to put lines at different sites in different holes, and all those, whenever we break the natural barrier, which is the skin or the nose and the oropharynx, or the abdomen or the peritoneum, we are going to expose the naturally sterile area to the environment, and then we are going to predispose those areas to infections. So the commonest infections that we worry about in the hospital are ventilator associated pneumonia, that is VAP, CRBSI is the catheter-related bloodstream infections. Remember, we put a lot of central lines, hemodialysis caths, PICC lines, LA lines, some cardiac monitoring lines. So all of these, we are going to be breaking the natural skin barrier and predisposing the patient to kind of an infection. CAUTI is the catheter-associated UTI. SSI is the skin and soft tissue infection that usually occurs or may occur after a surgical intervention. And when do we call this as an outbreak? So you may get random episodes of a VAP maybe, or in some other patient you may get a CAUTI, or in some third patient you may get a CRBSI. But if you get 2 or more cases which relate to the same place and time, so you have 2 patients who come to you in the ICU after an operative, and within 48 hours of coming from the operation theatre, develop a similar kind of an infection and grow a similar kind of an organism, then we say this is an outbreak. Or we need to define, or we need to at least suspect this to be an outbreak unless we can prove it to be otherwise. So this is the outbreak. So you should get a cluster of infection which is related to the same place and same time, and all these cluster of infection need to be investigated further. So just to take a small detour on the roles and responsibilities of hospital infection control team, this is a small topic here, how to investigate outbreaks. So first thing you need to do is to recognize that something has gone wrong. You'll have to identify the site, the pathogen, and the affected population. So, just because those 2 patients after a surgery came to ICU and got recognized to have a similar kind of an infection, the HIC team will have to go back to the OT, find out how many patients underwent any kind of an operative procedure in last 1 week, and go trace all those patients into the different wards that they may be in, and investigate to see if any of those also carry the same infection. Okay, so this is how, and so is it that every time you have to go back 1 week to see how many patients got infected? No, the time will be dependent on the incubation period of the pathogen. So if you have an outbreak of a viral infection or an outbreak of measles, because one of the OT staff had measles and he did not inform anybody in the hospital and continued to work, and therefore every patient and every person who came in contact with him also contracted measles. We all know measles has a incubation period of around 3 to 5 days before fever and rash starts. So you will have to investigate everyone who came in contact with that staff who had measles in the last 5 to 7 days, because some patients may be able to hold off the infection for a couple of days longer. So you will have to define that outbreak in terms of time, person, and place. Hypothesis regarding a source and spread should be made. You need to find out that who was the source, who or what was the source. So supposing you have an operating table which was not cleaned between patients, and the previous patient had some MRSA going on, which was a dirty contaminated surgery, and the next patient was taken, and then the subsequent patient grows MRSA in the postoperative period in the skin. You will have to find out how many patients subsequently grew MRSA and then trace your step backwards to find out who became the primary event. Who was the primary event? So the first person who had a clean contaminated surgery, who spilled some MRSA onto the operating table surface, and then the table surface never got cleaned, and then subsequent patients who got operated on the same table contracted that infection. So you will have to trace your steps backwards and as well as forwards. You will also have to take relevant samples, because not everybody who gets a contamination because of a microorganism will show an infection. But you cannot wait, or you cannot say that okay, itna din ho gaya to abhi infection nahi hoga. You will have to take relevant samples, and you will have to make sure that it is not going to jump from one to another person otherwise. you will have to isolate or cohort depending on the case. So if it is an MRSA outbreak that you are thinking about, it is isolation, because MRSA inherently is very resistant to treatment and it can spread very quickly. Or you will have, if you have a couple of patients or a few patients and you have enough rooms to accommodate those patients, you will have to isolate them. Otherwise, if you have a larger outbreak where you have 10 or 15 patients all developing the same kind of infection, you will have to open up a ward, and irrespective of what their specialty is. So one may be a respiratory patient, one may be an abdominal patient, one may be surgical patient, one may be an orthopedic patient. So irrespective of their specialty or why they came to hospital, you will have to cohort them all into one area. So put all those 15 in one area, make sure nobody goes in and nobody comes out till that infection is investigated, treated and cured. So this is how you will have to separate the infected individuals from the non-separated individuals. And you will obviously have to inform relevant departments. So starting from the CEO of the hospital to the microbiologist, to so if an orthopedic surgeon has operated on, say, X patient, the orthopedic department will also have to know that this is what has happened and there has been an outbreak. All the more reason because the patients who get prosthesis inserted, some metal work done, they may have some brace inserted, some screws, rods or some something else inserted. Infection of the prosthesis can be very devastating for the patient. It takes a long time to heal. Sometimes the prosthesis need to come out. So what I'm trying to say here is all relevant departments, personnel and hospital administration will have to be informed. You will also have to inform the family members of these patients, and in an ideal situation you need an epidemiologist who are trained, who are an expert to trace these kind of outbreaks in the hospital. So infection, so this all will come under the gamut of hospital infection control team and hospital infection control committee. Now, this we talked about, investigating, cohorting, isolating, and then informing about hospital outbreaks. But our primary aim is to be to prevent infection happening in the hospital. So how do we prevent infection? What are our infection prevention processes? So if you see that the blue chat boxes that I've done there. So there basically we have three. One is the hand hygiene, second is the surgical hand scrub, and third is the use of PPE. Now I think COVID has put hand hygiene and in focus worldwide, and all of us now know that we follow WHO recommendation of 5 moments for hand hygiene. And what are the 5 moments for hand hygiene? Moment one is before you touch the patient, before you do any kind of aseptic task, after you touch body fluid, or you have had an exposure to or a risk of touching the body fluid like urine, saliva, endotracheal secretions, some soakage that may be happening at the surgical site. You have to change those dressings. After patient contact, so after you've touched the patient, you better clean your hands, because point number 4 and 5 deals with your protection, healthcare staff protection, as compared to point number 1, 2 and 3, where we are dealing with patient protection. So these are the 5 WHO 5 moments of hand hygiene, and I honestly cannot stress the importance of hand hygiene enough here. If you come to any hospital, any tertiary care hospital, you will realize the incidence of healthcare associated infection, especially with drug resistant organisms, and we have no way that we can save these patients. Inherent risk of dying is almost 30% if anyone gets contracted with a MDR organism. The second one of infection prevention process is your surgical hand scrub. So all your OT procedures, so whether it is a big supra major procedure, or it may be as small as a small abscess drainage on a finger, everything needs a surgical hand scrub. And these are the points, these are WHO recommended points of how to go about doing a surgical hand scrub. And infection prevention processes cannot be successful until even the porter and the mama maushi of the hospital are trained in WHO 5 moments of hand hygiene and surgical hand scrub. It just cannot be successful. So all the training will land up in the HIC committee's court. And the third way you can, the third infection prevention process is the use of PPE. Now, when we are talking about PPE, we are talking about healthcare staff protection. So contracting HIV from treating an HIV patient, contracting COVID from treating a COVID positive patient, getting a tuberculosis infection because we were treating tuberculosis patients should not happen in this modern day and age where PPE are available. Now, when we talk about personal protective equipment, it is not just the whole kit, from going from top to bottom, because that may not be suitable, or in fact, it may not even be needed for certain conditions. So just wearing a N95 mask with goggles, with cap and gloves would be enough for a patient where you need to do contact precautions. For patients where you need droplet and aerosol precautions, you may need to do the full gear. So use of PPE is a different chapter completely, and there is a big write-up in the WHO website. And the use of PPE needs to be limited because all of these are environmentally non-friendly material. So it needs to be limited. It needs to be used accurately and in accurate situations, in relevant situations. Just every day when you come to the hospital and you're covered from top to bottom makes no sense. So it is absolute waste of PPE. Plus, if you use up all the available resources that you have, you won't get any when you really need them. So make sure that you are if you are part of the HIC, you train staff appropriately on use of appropriate PPE. It is not a blanket use for all patients. So, so how do we prevent? So then we come to these the HCAI prevention bundles. So the best way to do a ventilator-associated pneumonia prevention, apart from training and apart from teaching all your nursing staff and doctors on how to wash their hands, how to do a surgical scrub, how to wear PPEs, is to have something that will very easily demonstrate essential care in a very short method. Okay, so that is what we call as bundles. So we are trying to give important essential care points in a very small, short, catchy format, so that people tend to remember. Otherwise, it is very difficult to get compliance to prevention processes. So when we talk about VAP care bundle, the elements of VAP care bundle are head of bed elevation, which is 30 to 45 degree. Most patients who are on ventilator will be sedated. So you need to do a daily sedation hold. So stop sedation for a couple of hours and see if the patient wakes up, is he able to breathe, or is the patient just thrashing around, trying to pull their tubes, lines, trying to kick you, that kind of a thing. You will have to do, because these patients cannot perform their oral hygiene or brush their own teeth. The nurses will have to be taught to perform oral hygiene every 12 hourly. You will also have to do 2 hourly subglottic suction, 4 hourly pressure checks. The endotracheal tubes that we insert have cuffs, and those cuffs exert pressure on the trachea. So those cuff pressure have to be checked at least once in a shift to make sure that the pressure remains between 20 and 30 centimeters of water. Anything more than 30 centimeter of water can hamper blood flow to the trachea and cause more complications. And the sixth thing we want is the stress ulcer prophylaxis. So when all these essential care elements are applied together in a patient who is ventilated, it becomes a ventilator associated pneumonia care bundle, so, or a VAP bundle. The same we also have for a COUTI, which is a UTI. The mnemonic is called as caution. So C stands for a closed system. So that means the Foley's and the urine bag need to be a closed system. You cannot let it be open to atmosphere at any place, because that causes more contamination and increases risk of infection. It has to be an aseptic management. So anybody who is inserting a urine catheter should perform a hand wash, a surgical hand wash, and then use asepsis to insert the urinary catheter. So the universal standard precautions will come there. So sterile gloves, gown, maybe a mask and a cap. So universal precautions. The urine catheter needs to be tied to the secured to the patient, and the tubing should be secured to the bed. So you can't let the urine bag fall onto the floor. You also need to understand why we have inserted a urine catheter and for how many days that catheter needs to be kept in situ. As soon as you realize that urine catheter need not be in place for any more time because patient has recovered, patient is able to walk, a patient will tell us when if he wants to pass urine, then the urine catheter should come out ASAP. The urine cannot, so you can't have kink and bends in your urinary in your catheter tubings. So the urine flow should be obstruction free. And if you have to collect urine sample for testing, then you cannot disconnect the urine catheter bag and the Foley's. You should have a separate sampling port from where you can aseptically draw out samples without disconnecting the entire connection. And you cannot have dependent loops. So this becomes a COUTI bundle. Similarly, we also have an SSI bundle, a CRBSI bundle. For surgical skin infections, we don't have a bundle. It has to be adapted to suit local needs. So whenever you work as a part of a hospital infection control committee, you make sure you understand what kind of operations the hospital does on a regular basis. What are the major operations that are being conducted there? What are the kind of infections, if any, are seen there? And you will have to formulate, or you will have to improvise to formulate certain bundles or certain care elements to help reduce the chances of surgical infections. And some of the points here is for surgical site infections are you need the SSI prevention should start in the pre-operative phase. So pre-operatively, don't keep patient hospitalized for a long time because they will catch something in the hospital. So the best scenario is when the patients get admitted on the morning of the surgery. So ask the patients to get admitted at 6 a.m. for a 9 a.m. surgery. All the screening, all the pre-operative investigations can be done on an OPD basis. So patient can come 2 or 3 days prior to the surgery, the date that the surgery is fixed on, and get all the other investigations done. If the patient is undergoing a major prosthesis surgery where a lot of metal implants are going to be put in the patient's body, then they should be screened for MRSA. So depending on whether the patient is having a knee replacement or some CABG or some very fancy brain implants being put in, it is prudent to get them screened for an MRSA. Do not ask patient to shave their body hair. You know, we all know that before surgery, the surgeons don't like to take incision when the skin at the site of surgery has hair. But we have moved from the time where the surgery was done 3 days in advance and then the patient came to the theater. Now we don't do these things. We don't shave body hair. Patients compulsorily have to have a bath before surgery. Do not allow patient to come to OT without a bath. And antibiotic prophylaxis should be given at least 30 minutes prior to incision. So these are the steps that you will take or you will need to take to reduce surgical infections in the hospital. Now, when this we have all these bundles that we talk about are individual based bundles, right? So your hand hygiene, surgical scrubs, wearing of PPE kits are hospital staff based bundles. Your VAP prevention, COWT prevention, surgical site infections, or CRBSI prevention are patient based care bundles. But you will also have to you'll have to keep a check on what is happening in the environment, how you are cleaning the area, how are the instruments getting disinfected or sterilized, depending on what the instruments are being used for. So between two surgeries, environmental cleaning becomes extremely important. You cannot just let the whole thing be messy and then take the next patient. Cannot do that. So cleaning between theaters can take even up to 20 minutes. And I would prefer that the surgeons don't pressurize the nursing staff or the OT staff to take the next patient quickly. What happens is when you pressurize these staff, they start finding shortcuts, and what they don't do is what will harm your patient eventually. The importance between disinfection, or important difference between disinfection and sterilization, is where you are going to use the instruments. If the instruments are going to penetrate the skin or the mucous membrane barrier, those instruments need to be sterilized. And the sterilization, so whether it is sent for autoclaving or whether it is sent for ETO sterilization, depends on manufacturer recommendations. So you cannot, if an instrument is only to be ETO'd, you cannot send it for autoclaving. A, because it will lose the efficacy of the instrument, and B, because we may not get a completely sterile equipment to use for the next patient. So these are the ways. The instruments that are not going to penetrate the skin and mucous membrane barriers, or are just going to come in contact with intact skin, they can just be plainly disinfected, and they may not need to be sterilized. Now we are moving, when I was a student, everything was reused. Now we are moving towards more and more single use equipments. So ECG leads that we use are single use. Even in some areas, we use BP cuffs that are use and throw. Small suture cutting needles, scissors, some materials, they're all single use. So you use it once for a patient and you just bin them, just put them in the dustbin. So I think it is a wasteful resource. But if you are dealing with patients who are extremely contagious or extremely infected, it probably makes more sense to do that way. But again, I will leave that prudence to the infection control team. So it is just not about how the management, how the personnel in the hospital handle cleaning and infection prevention processes. It is also about environment. It is also about instruments. It is also about monitoring devices. So how your endoscopes are cleaned, how are the monitors cleaned, how are the chairs, nursing stations cleaned. So all this comes under the gambit of infection prevention process, and obviously under the gambit of infection control team. The next most important aspect of infection prevention and hospital infection control committee is biomedical waste management. And again, all hospitals are now supposed to sign an MOU with the government, without which license to run the hospital is not available. That they are going to very diligently manage biomedical waste at source. It is not that you put everything in one basket और वो waste management company को भेज देने का, and then they will decide कि कितना कैसे segregate करना है. So the segregation has to occur at source, and it has to be sent in similar colored bins. So your yellow waste will go in a yellow colored bag. The red waste will go in a red colored bag. And so the segregation occurs at source. The training and implementation becomes a part of HIC rule. The other thing you will have to implement is the spill code. So supposing patient vomits, or patient has a huge blood vomit and the entire bed and floor is filled with blood. So can you just use a mop, clean it up, and use the mop again after 2 hours to clean the floor of the ICU? No. You cannot do that. So what we do is we need to have a spill code. So whenever there is body fluid spillage, or infectious material spillage on any surface, not just the floor, any surface, you have to activate that code, and it is called the hazmat code or the hazardous material code. And once you activate that, there are certain ways in which there is a certain protocol in which the material needs to be cleaned. Then we come to the isolation. So biomedical waste segregation at source, cleaning of hazardous material, all comes under the gambit of infection control committee. Then we come to the isolation practices. So remember, certain infections, you may have to isolate patients in different wards. So what does isolation mean? So isolation can be of three types. It could be contact isolation, droplet isolation, and aerosol isolation. Now with COVID, we all know the COVID, certain procedures in COVID patients can be aerosol generating procedures, and you need to have certain facilities to manage those patients there. So what are the general principles of isolation? You need to understand what is the route of transmission of the infectious agent. If the transmission is, hands touching contaminated surfaces and those hands then touching another patient, then you need to have contact precautions. If the route of transmission is I cough and somebody in close contact with me breathes in, and whatever I put out in the cough gets breathed in by the next person, then these are called as droplet infections. So when you have droplet and aerosol transmission, you will have to have different kind of isolation facilities. So let's talk about the contact precautions. So commonest examples are when patients have infective diarrhea, they have multi-drug resistant organism infections and some skin lesions. All these patients can be kept, or you can cohort the similar patients together and maybe form one area where they can be kept together. Single rooms obviously are preferable because then they don't come in contact with other patients. For staff, you may have to use PPE like gowns and gloves. Remember, it is a contact, so unless you touch the patient, you are not going to be a transmission agent. So every shift you will need new gowns and new gloves. Equipment cleaning, follow regular protocols. Environment cleaning, follow regular protocols. When we talk about droplet precautions, we know now COVID, influenza, meningococcal infections, you need to have droplet precautions. So the kind of PPE you will have to wear is mask, maybe a visor, caps, goggles, gloves and gowns. If you are not coming in close contact or direct contact with patients' cough or respiratory secretions, just wearing a gown is enough. But if you are going to intubate these patients or do a bronchoscopy or maybe perform a lung surgery or something, you may have to wear an entire PPE kit. Aerosol precautions, again, these patients need to be segregated. Individual rooms are the best, but if you can't, because every hospital will have a limit on how many individual rooms they can have. So if you can't, it is a good idea to cohort similar patients together. Same about aerosol. The commonest aerosol or the most transmissible aerosol infections are pulmonary tuberculosis, herpes zoster, COVID, and chickenpox. You will need aerosol airborne infection isolation room, which are also called as negative pressure rooms. Those rooms should have 6 to 12 air changes per hour, and that exhaust should empty out directly into the atmosphere, or you may have to put HEPA filters in between if the air is being circulated to the whole hospital. You need to have a monitor for air pressure control, and you will have to have the door has to be, so you will need a dual door room where the outside door, the space between the outside and the inner door becomes the area where you don the kit, you wear your PPE and you remove your PPE, and the inner door which acts as a air curtain, so it doesn't let air from inside the room come mingle with the air outside the room. Okay, so these are aerosol airborne infection isolation rooms. Again, these rooms are even fewer in the hospital, so very difficult to keep more than 10 patients in any big hospital in India. The one more thing that comes under the gambit of hospital infection control policy is the antimicrobial policy. What most hospital does is there is a national antimicrobial policy. So it works on the background of the national antibiotic policy, and then depending on what kind of organisms they see in their community, so which is a local area in their community or in their own hospital, some of the factors can be modified. So again, you will need a microbiologist, you will need an infection control nurse, you will need lot of biological samples to find out exactly what kind of microorganisms we are growing. And when you do all of that, you may also have to have find out the incidence of MDRO. You may have to institute a policy which is called as restricting antibiotic policy and antibiotic stewardship. I don't think, apart from a couple of hospitals, I know any hospital in India has been able to implement a complete antibiotic stewardship. Most hospitals, what they do is have a restricted antibiotic policy. You will have to do prescription audits, so which are called as live audits. So every patient who is admitted in the hospital, you need to find out whether these patients have any infection or a suspicion of infection. So if there is a suspicion of infection, have appropriate investigations been sent? And if those investigations have been sent, are the reports back? And if the reports are back, do any of the reports indicate that the person has the infection? If none of these are present, that means even though there was a suspicion of infection, there has been no infection that has been found. So the day where we are sure that there is no infection in a patient, all antibiotic prescriptions have to stop. So are all of that happening in genuine order? And if not, what we realize when we look into our own hospital practices, that almost 50% of the antibiotic prescriptions are not indicated, to an extent that anybody who comes with just uncontrolled sugar gets one baseline antibiotic. So all these practices need to be gradually changed. What it leads to is it leads to an overuse of antibiotics. India is one of the first, I think it is the third country in the world to have maximum per capita use of antibiotic in the entire lifespan of a person. So we start antibiotics right from babyhood, isn't it? Our babies, they get viral infection. The mothers and fathers, they don't sleep for 2 nights because the child is crying all night and somebody has to, carry them and keep them quiet. The third day, they will go to the GP and say, "Nai kaitri antibiotic deun takavo te khub radtay baal." Okay, even if the GP knows that this child has an infection which is viral, it will take 5 days to settle down. But because the GP does not prescribe that antibiotic, what will the parents do? They will find another doctor who will prescribe that antibiotic. But they will not go home without prescription of an antibiotic, which is completely unnecessary. So this is what, so this, we are not only talking about hospital data, we are also talking about community data. So we are actually just over prescribing antibiotics to an extent that by the time that child grows to adulthood and comes to us, they carry a lot of resistant organisms within their microflora, and we cannot do anything about it. Okay, so antibiotic stewardship, establishing antibiotic stewardship in the hospital again becomes one of our duties. And the last thing that comes under the gambit of hospital infection control is occupational hazard and safety. So the nurses, the healthcare staff, the porters, the people who will segregate the waste, biomedical waste, doctors, surgeons, obstetricians, at some point or the other will get some needle stick injury, which is the needle or the sharp instrument contaminated with patient's blood. And if the patient is known to have HIV, hepatitis B or hepatitis C, and gets across penetration to the doctor or the healthcare staff, the possibility of the healthcare staff contracting one of these infections is going to be high. So you are going to have to form policy to deal with these kind of injuries, and and to make sure that every sharp injury to the staff, healthcare staff, is reported due precautions are taken. We need to find out why that injury happened. So corrective and preventive actions are done. Maybe retrain the staff to handle, if they are handling biomedical waste on a regular basis, on a daily basis, because that's their work. You'll have to train them more and more rigorously to make sure they understand what kind of risk they stand when they handle this kind of waste material. So this is the entire scope or scope of service or scope of practice for hospital infection control team. And if I just label them in a few words, it is prevention of healthcare associated infection, biomedical waste segregation, surveillance not only of the staff, the healthcare workers, the food handlers, but also of the environment, the disinfection and sterilization processes that are occurring for everything that touches a patient's body. Formation of antimicrobial policy and making sure it's implemented, the occupational hazard that people working in hospital environment face, and when all the policies have been done and you are trying to implement them, remember you cannot complete your scope of service unless you train the staff involved. So this is as per the National CDC guidelines, the scope of service of Hospital Infection Control Committee.